Hey guys, it's Tara Marie. I'm here at the Hangar Studios. We're about to do another pre-record of my podcast. This week I'm talking to Dr. Mark Menolascino. He's the author of Heart Solution for Women. It's a very comprehensive guide about women's heart health and prevention and treatment of heart disease. Dr. Mark, I know that heart disease is the #1 killer of women now at this point worldwide.
It absolutely is, and we're going to change that.
We're going to change that. We can change that with some holistic practices. Stick around for this show. I'm Tara Marie, and I'm a fitness expert, personal trainer, and motivational strategist. Optimal health is achieved when you're balanced mentally, emotionally, physically, socially, and spiritually. My goal is to bring you information that will help you be the best version of you. Hey, well, hello and welcome to Tara Marie Live. I'm your host, Tara Marie Segundo, and I'm a fitness expert, a personal trainer, and a motivational strategist. And we're coming to you today from the Hangar Studios in beautiful New York City. Tara Marie Live is about mental, emotional, physical, social, and spiritual health, and how these parts of us are all inextricably linked, so much so that they have a very profound effect on each other. Now, today's show is an important one because it addresses something that is literally devastating women's health on a global scale, but it's significantly preventable. I'm talking about heart disease. Heart disease was once thought to be a man's problem, but now it's the #1 killer of women. And get this, more women suffer from heart disease than from cancer, diabetes, and stroke combined. 1 in 4 women will develop heart disease in her lifetime. Heart attack rates are rising among middle-aged women, but interestingly, rates are dropping among middle-aged men. So what happened? How did we get so far off course that women are dying unnecessarily? My guest today actually acknowledges that, quote, "When it comes to women's hearts, we've made some of the biggest mistakes in the history of human health," end quote. Now, it's scary when you think about it, but thankfully my guest has dedicated his entire career to trying to bridge the gap and get to the root of why women are suffering and what to do about it. So please welcome my guest, Dr. Mark Menolascino. Dr. Menolascino is the medical director of the Meno Clinic, Center for Functional Medicine, and is one of few physicians who is board certified as an internal medicine specialist, board certified in integrative and holistic medicine, board certified in advanced hormone management and anti-aging medicine, and is a certified functional medicine practitioner. He also has a master's degree in pharmacology and immunology and was a doctoral candidate in the medical scientist program assisting with clinical trials of new medications. He also worked as part of the heart disease reversal team with renowned physician Dr. Dean Ornish. Dr. Menolascino's medical knowledge is complemented by advanced training and clinical experience in nutrition, naturopathic medicine, Chinese medicine and acupuncture, Ayurvedic medicine, and homeopathy. Hello, Dr. Mark Menolascino.
Hello, Tara Marie. Thanks for having me today.
You know what I thought of when I was reading your bio to prep this show? The only thing that's missing from this bio is that you take in foster children and that on the weekends you volunteer at the no-kill animal shelter.
Well, I'm actually preparing for my 5th board certification this summer.
In what?
In integrative. Integrative medicine is now a medical specialty like cardiology. It just got certified last year as a formal medical subspecialty.
Just last year in 2018?
Yes, it's very exciting.
Wow.
Yeah, so
and is it a national board certification that's available in all states?
It is. And it's the same subspecialty credibility as the subspecialties of cardiology, kidney specialists, dermatologists. It's a subspecialty.
So it's finally getting some respect.
Finally getting some respect. It's very exciting.
It's taken long enough.
Yes.
It's taken long enough. We're here today talking about your beautiful book. I want to hold up this book to the camera, Heart Solution for Women. This book has 332 pages of content. It has more pages than that because some of it you also offer some, pages to write down notes and dietary records and things like that. But it's 332 pages of content. This I will tell you, and I read a lot of books for this show, this is the most comprehensive guide I've ever seen.
Thank you.
And I want to congratulate you on this book. It is available now. It's just out, but it's available now wide.
Yes.
Everywhere books are sold. So this is an excellent book. This is what we're talking about today. And I want to get right into it because I don't want to waste a minute. I want you to really lay it out for people because when I read, it's funny because at the end of your first chapter, I think you said, now, if this makes you upset or if this frustrates you, I get it. And I did feel very frustrated and frankly kind of pissed off as a female at the end of the first chapter. But before we get into that, I do want to talk a little more about this functional medicine specialty because you are a specialist in functional medicine. You just revealed that you're getting your 5th board certification. Explain to people so they understand the vantage point of this book. How is this different from the medicine that many typical medical doctors, well-meaning medical doctors, not to disparage anybody, but how do you differ in your philosophy and in your practice of medicine, and then therefore what you convey in this book?
Well, it's really about a personalized approach, and women are the ones that really didn't get a fair shake. Now, if you and I go to dinner and both get chest pain, I'll get admitted to the hospital and evaluated for heart attack. You'll get sent home with anxiety medicine or heartburn medicine.
Okay, why though?
It's because of the way we think about women's heart health. Last year in Grey's Anatomy, there's an episode about this where the chief of surgery...
You wrote about that in the book, but I didn't realize it was last year on Grey's Anatomy.
It was. And so and we're seeing more and more people recognizing that we just have not done a great job for women. Most of the studies are on men, and women are not men. And their anatomy is a little bit different of the heart. The vessels are a little bit different. Their inflammatory risks are different, and their hormones are different. So it's really much more complicated for women's heart health than for men's, and we've just not done a great job of it.
And explain as a functional medicine doctor, as opposed to, let's pretend you weren't a functional medicine doctor, your regular average Joe MD, not coming from a functional medical perspective. How is your perspective different as a functional medicine doctor? Because that's the whole philosophy that you teach in this book.
Well, it started with holistic medicine with Dean Ornish, treating the whole person. Then Andrew Weil brought in integrative medicine, integrating natural and nutritional medicine with traditional medicine.
Okay.
Now it's functional. It's looking for the root cause, a precision, personalized approach to your health.
Yeah.
So instead of treating you like the bell-shaped curve of a population, it's the N of 1. I treat you as the unique individual that you are. That's what women have been looking for decades, and it's finally happening through this model of functional medicine.
And how did you get interested? Because you're an internal medicine doctor. How did you get interested so much in heart health specifically? Is it because it was so understudied and undervalued by other people? Were you just like, I need to bridge this gap? Like,
yes, and it was really a passion of mine that to do women's health better than we were taught in medical school.
Okay.
I'm taught to spend 7 minutes with my patients so I can just adjust their medication based on their numbers of their lab tests.
Okay.
Not really listen to, what's your story? How did we get here? Where do you want to go? Let's listen to these passions. What is it that really helps spark you every single day to live a vital life? And this functional approach is what women have been looking for. The heart is a big problem. The thyroid is the other one. There's millions of women in America that have a thyroid problem.
Yes.
But they're told they don't because they're not out of the normal range, which has been changed 8 years ago, by the way. So there's a lot of things that we're just not personalizing our medicine for the women.
Well, right. And also, again, you look there, of course, there's a normal range, but what I was always taught, because I am a thyroid patient.
I didn't know that.
Yeah, I am a thyroid patient, Hashimoto's thyroiditis, and I talk about it on the show.
Great.
So there's a normal range, a low end of normal and a high end of normal. But what my doctor always taught me is, well, what end of normal is better for you? Like, in other words, because a lot of people are walking around and their doctors say, but honey, you're normal.
Yeah.
But is that optimal? I don't want to be normal. I want to be optimal. And so you take the approach of, instead of like, let's just look at everything and call it normal or not, let's optimize your health. And that's what this book is about. How do we optimize your health?
Exactly. That's the functional medicine approach. It's a root cause for you. And you're so right about these normal ranges. I use the Grand Canyon analogy. You can be standing on the south rim of the Grand Canyon or the north rim. You're still technically in the Grand Canyon, but isn't your view different? Where's your view the best? And we look at every normal range with those values in mind. Where's your sweet spot? How do we find it together?
I hope that you functional medicine doctors sort of pull along other MDs, philosophically, that is. I hope you sort of pull them along.
It's a partnership.
Yeah, I hope you do pull them along.
Yes.
Because sadly, I find a lot that still think in terms of black, white, normal, abnormal. Nobody's talking optimal.
Yes. Well, we're not talking about alternative medicine either. Alternative medicine is what you do when regular medicine doesn't work.
Right.
And acute care medicine, which I'm taught in my internal medicine training, if I have pneumonia, I want that antibiotic. If I have a blocked artery in my brain, I want that clot-busting drug. But it's the chronic illness that medicine is not trained for and prepared for. This tsunami of chronic illness, of diabetes, obesity, heart disease, dementia. We don't have tools in our toolbox for that coming out of medical school.
Chronic. And again, you are an MD. So I just want to say, because I interview a lot of naturopathic physicians here. You're an MD who has also studied naturopathy. Okay. Now, I alluded to this in the open. When you were a young doctor, we were already a young doctor, yes?
No.
You weren't a doctor yet?
I was going to be an astronaut, and Dean Ornish showed up to Omaha, Nebraska, where I'm from, and said he's going to take 100 men who have had heart attacks, are scheduled to get their chest cracked open and get bypass surgery.
Okay.
And he's going to talk them out of it.
But you weren't a doctor yet?
No, I was a high school senior.
Excuse me. So you were a high school, okay, so you were a kid.
I saw
You hadn't even
this.
gone to college yet.
Yeah, I saw this in the very beginning.
Tell the story.
So I saw Neil Armstrong walk on the moon when I was 7 years old, and that's what I wanted to do. So I was the #1 math student in my state. And I thought that's what my career would be. And I met Dean Ornish and saw that lifestyle medicine, teaching people how to eat, how to exercise, how to deal with stress, and how to have love and support in their bodies. They actually did better than the people that had the bypass surgery. Now, 35 years later, guess what? His group still is better than the people that had the medication and the bypass surgery.
So take us back. So you're a high school student. How did you get mixed into this? So Dr. Dean Ornish came and said, hey, guys, I'm going to take this group. They're all scheduled for surgery. I'm going to convince half of them to forego surgery at first and instead try my way. And then I'm going to let the other half have their surgery.
Yeah, my father was chief of psychiatry, and he thought Dean was crazy. But Dean showed up with the biggest afro I've ever seen.
Okay.
In the late 70s, and he was just a rebel, but also he was so confident that the lifestyle medicine, because he'd been doing it himself for years with patients.
Okay.
But it needed the clinical trial validity that he was able to bring, and he wrote a book called Reversing Heart Disease.
And how many men were in this group?
The first one was 50, and then it was 100. They've now done some of them with women.
Okay.
And Dean has helped bring this program all around the country. It can be everywhere. Medicare pays for it. Blue Cross pays for it. So a lot of the insurance companies, even Medicare, sees value in it, which is a hard thing to pass that test.
And again, with this that you participated in with Dean Ornish, the gentleman who opted out of surgery did better than those who underwent a surgical intervention.
One of the neat things about that was we had weekly group support where you had to bring your spouse and you came each week and met. And we found the people that got connected even further, that went to dinner, went bowling, did things outside of the group, but together, that social support, those people even did better.
Got it.
So it's this combination of lifestyle medicine, nutrition, stress management, exercise, and having some love in your life.
Connection. Yeah. Now, chapter 1 is entitled Unfair to the Fairer Sex. This is the chapter that did piss me off, but you knew it was going to piss us off. And we know that heart disease is the #1 killer of women, and more women suffer from heart disease than from breast cancer, diabetes, or stroke combined, which I find hard to believe.
It's amazing.
I find that really hard to believe. Why are the statistics so grim for women now? Because, am I mistaken? It wasn't always like this. Am I correct? It was not always this bad.
It's been this bad for a long time, but no one's really shown the lens on it. I don't think we wanted to admit how bad we were at it. We're still arguing about whether we should be doing cholesterol drugs. We're still arguing about some of the other therapies that we're doing for the heart. But what we do know is that more women are harmed, and they actually have a higher risk of dying from their first heart attack. And half the women who have a heart attack, their first warning sign is sudden death heart attack. You don't get a second shot. So it's that critical. It's that important.
But doctor, so when we were little, and we're 3 years apart, you and I, so we're basically the same age-ish. When we were little, was it like this? Were women, because for some reason I had the impression when I was a little kid, I didn't see a lot of women's heart disease. I didn't. Mm-hmm. That was more of a man thing, like a fat old man thing. So my feeling, just my observation, is that it's gotten worse for women. Is that at least accurate?
I think it's the challenges on women today for their health are so vast. It's so hard to be a woman, and that's coming from a man doctor because I see them every day. The challenges, you're trying to take care of yourself, take care of your partner, take care of your kids, take care of your dog. Mm-hmm. You're the caregivers of our society, and that makes it even harder. They've done studies with Alzheimer's that the caregivers of Alzheimer's, who are they? They're women. They're taking care of men. Mm-hmm. And taking care of someone with Alzheimer's can cause memory problems.
Because it's so stressful.
The stress and the cortisol and the inflammation. It's the same thing with the heart. Fire in the gut, fire in the heart, fire in the brain. It's all about inflammation.
Because I feel like this has really gone off the rails a little bit. I mean, you said in the book, nearly all treatments for heart disease are based on scientific research that are done on men. So we're treating women with protocols that were tested on men.
Yes.
And this is a key reason that women who develop heart disease have worse outcomes than men. So why are researchers not using women in research for the basis of their studies? And is this changing at least?
It is changing, but historically women were not part of clinical trials unless they were women-specific medications or treatments. So it's been studied. Mm-hmm. Men are the ones that have been studied, not women. And when we were growing up in the 60s, there weren't even cholesterol drugs yet. We didn't even know about this whole problem of cholesterol. That didn't really develop until the 70s. So our knowledge of heart disease is expanding all the time. But I think our priority of looking at women as unique individuals and not just as a different type of body, that we are now really thinking about the nuances and the individuality. Okay. And that's where this functional medicine really shines. It's a personal approach.
So the tide is turning, though. They're starting
Absolutely.
To do research with women?
They are, yes.
Because another statistic that you said in the book that was very disturbing, I thought, was that you noted that women between the ages of 40 and 59, which I think is very young, 40?
Yes.
I don't even remember being 40. Like, no, do you remember? I don't remember. 40 and 59 are up to 4 times more likely to die from heart bypass surgery than men of the same age. And all women are twice as likely as men to die within the first few weeks of having a heart attack. So let me reiterate what you said.
Yes.
Woman 40 to 59 goes in for heart bypass surgery. She's 4 times more likely to die post-op than a man. Why?
Part of it is the anatomy. When I was in my anatomy class in medical school, I was fascinated how really diverse we are. And the men and women's hearts look different. They're different sizes. The blood vessels are different caliber. The coronary arteries, which are the ones that get blocked in the heart, they're different in men than women. And the hormone changes that women have daily, weekly, monthly, throughout their lifetime affects the lining of the blood vessel in a different way than male hormones do. So a woman's heart is always changing, and it makes it more vulnerable.
And that's why, let's say a woman 40 to 59 has surgery, and she's 4 times more likely to die after that life-saving surgery.
And you could have done it with lifestyle medicine. It just boggles my mind that you wouldn't try that first. They've done a study at the YMCA in Minneapolis looking at diabetes, lifestyle medicine versus the leading drug for diabetes.
It starts with an M.
Yes.
Metformin.
Maybe.
Okay, yeah.
It beat it out. Lifestyle trumped the first-line therapy for diabetes meds. So why would we not try that first for everybody?
For everything. Yeah, for
everything.
Why are women twice as likely as men to die within the first few weeks after having a heart attack? So you've had your heart attack, you've been medically stabilized. Why are women twice as likely to die?
Part of that has to do with the female hormones. The estrogen is a really clot causer. It likes to make blood sticky. And so women are already at a higher risk, as are overweight men, because overweight men make more estrogen.
Right.
And we'll talk about the body types and who we really worry about with estrogen, this thing called estrogen dominance.
Yeah.
Which, when the adrenals are stressed, they steal the female hormones and your estrogen gets over your progesterone. And so that's one thing we see a lot.
So it's the estrogen that makes the blood sticky.
Yes.
And that's why we're kind of screwed. Okay, so that's that's kind of a double-edged sword, though, because in the book, and also I've anecdotally always heard that the estrogen is cardioprotective.
It is cardioprotective, but not at the stickiness of the clotting ability. So it's a real double-edged sword. Hormones are a real double-edged sword. And we're not going to mention the name, but if you're taking synthetic horse estrogen for women, it's different than bioidentical estrogen.
Whisper the name. Just whisper it to me.
It's the equine estrogen known as Premarin. It is a horse estrogen.
Okay.
Did you know that? Premarin, pregnant mare urine.
I wouldn't.
That's where the name comes from.
That's bioidentical hormone. Yeah,
that's not Bioidentical. That's a synthetic horse estrogen that we've been giving to women orally, so the liver processes it and makes things that may be not so good for the body. The studies are really all over the place about what hormones do for the heart, what they do for the brain, and it really matters what kind of hormone, but it also matters the balance.
Meaning synthetic versus bioidentical.
Yes. Why would you not give a woman the same that she makes in much lower concentrations and get absorbed through the skin?
Well, while we're on the subject, would you differentiate between synthetic? Because I've already decided, when I need to, I've already decided I'll do bioidentical hormone replacement therapy. I don't need it quite yet, but I've already made the decision that I will do it. But explain the difference between bioidentical hormone replacement therapy versus synthetic, please.
So the bioidentical is the same estrogen and progesterone that your body makes. And you can give it in a topical cream. There's other ways to deliver it. But
oral, you can take oral.
You can. The problem with oral, though, it's been shown to lower serotonin, which increases your depression risk.
Oral progesterone?
Oral estrogen.
Okay.
Yeah. Every time you take an oral medication, your liver has to chop it up into little pieces and metabolize it. And sometimes when it sees things it's never seen before, it makes bad particles out of it. And that's what we think may be going on with these synthetic estrogens, that the liver in the oral medication, as the liver processes the medication, it metabolizes it into things that may be dangerous for women.
And then explain what is bioidentical hormone replacement.
And then bioidentical is the same that your body makes in the same structural format, and you can use it topically so it absorbs through the skin and avoids that bypass metabolism of the liver. You know, every pill you take, 40% of it gets wasted by your liver.
Okay.
So you take higher doses of oral medications knowing that the liver is going to process 40% of it. And so you have to use higher doses, and it just seems logical that you would use the same thing a woman already has to support it.
And bioidentical is recognizable to the body.
It is. Yeah. They're both recognizable, but we do think that one may be a better choice, and most of my female patients just plain do better on it. I learned about this 25 years ago. There's still doctors that have never even heard of it. Bioidentical.
Seriously? I didn't.
Yes. A lot of doctors, there's a new wave coming. And again, what we're finding, it's the women. Mm-hmm. They're becoming educated. There's shows like yours. There's great information out there. They're getting this information. They're taking it, and they are making their own empowered decisions.
Yeah.
And we just have to be sure that we do it safely. The big study for hormones was the Women's Health Initiative. And they used the wrong hormones. They used the synthetic ones, and there was a higher risk of heart attack, stroke, blood clot, and cancer using estrogen. So we've blanketed them to all kinds of hormones, and I think that was a mistake.
Wasn't that study done in the late 80s or early 90s, correct?
And a whole generation of women were deprived of hormones when they really could have benefited from them.
Okay.
And what we know now is that in that group, the women who took the statin medications for their cholesterol, guess what their stroke benefit was?
Zero.
Yeah. Guess what their diabetes risk was?
It went up by
58% higher. Yeah. So there's just, I am not anti-medication. I'm appropriate medication for the right person at the right time. And I do use cholesterol drugs, but it's in people with known heart disease. They don't seem to help women very much. And that's a big part of what the book talks about is you need to help yourself and figure out how to get your body and fall in love with those arteries and get them as healthy as possible.
Well, so going back to the women in the reproductive years, you say that So during a woman's reproductive years, they have a heart health advantage over men, but you call that a double-edged sword, and you talk in the book about how it kind of masks a lot of issues. So by the time this woman now gets to menopause, she's like, it's like, what the?
Yeah.
Like, can you explain that?
Well, do you have friends that menopause is a piece of cake, and for others it's a nightmare?
One of my girlfriends, she told me she went through menopause, and she said she did nothing.
And it seems to be the adrenals. That the adrenals, when they're really shot and they're tired, this adrenal dysregulation or adrenal fatigue, some people call it, you have a thing called the cortisol steal. You know, I'm sorry to tell you, but you're still a cave woman, and I'm a caveman.
Yeah.
Your body doesn't care if you can reproduce if you can't run from the saber-toothed tiger.
Right.
So you have to have the adrenals firing all the time and be in reserve and ready, and they will steal all of your other hormones. It's called the cortisol steal. The adrenals will take everything and do this robbing Peter to pay Paul with your hormones. And that's what makes menopause so difficult for many women.
So is what you're saying is women who arrive at menopause with extreme adrenal fatigue, their hormones plummet faster and harder, and that's why It's so bad?
It does, and it's not just the level of hormone in the blood. It's a very complicated. The hormones work at the DNA level. They go to the inside of the cell and work at the DNA, and they're very complicated in how they metabolize and how they get processed. So it really matters, not just are you taking hormones, but are you exposing yourself to other endocrine disruptors? Are you eating bad food, drinking dirty water? Are you doing all the other things that keep the body clean? Then you may be able to tolerate some hormone disruption.
Okay.
But most of our society, most of us Americans are not in great shape. You mentioned the bell-shaped curve of average. What's average in America? It's diabetic and obese. That's not who I want to be. That's not who I want my patients to be.
Yeah, a great majority of us are obese, unfortunately.
And 1 in 3 children born today will be diabetic. 1 in 3. We can do better. And that's what this whole tide of functional medicine is. We're going to do better. We are doing better. We reverse diabetes. We reverse heart disease. We reverse obesity. All the itises, the arthritis, dermatitis, all of those things are reversible. And you just need to be able to dive deep, and you have to do some heavy lifting because it doesn't happen overnight.
And get to the root cause.
Get to the root cause.
Now, based on recent research, you tell women that if we improve our heart health, our risk of Alzheimer's disease and depression will decrease. You say heart health is brain health is body health. Because you even say in the book, like at one point, the medical idea was the brain is up here and then the body's from the neck down. But so how is improving our heart health improving our risk of Alzheimer's disease? 'Cause I got to tell you, I think the scariest disease is Alzheimer's disease. Don't you agree with that?
I do. And there's a new reversing dementia protocol developed by Dale Bredesen that actually works. It's a functional medicine approach to dementia. The single drug therapy, there's been something like 40 different drugs trialed. They don't work very well. It's not going to be a single drug solution.
Okay.
It's going to be this complicated approach. Why would you not look at a woman's hormones, her toxicity, her nutrient deficiencies? Why would you not look at the way the gut is metabolizing? Is there leaky gut? Are there food sensitivities? Why would you not look at all of these things to help a woman's brain? That's what we do to help her heart.
And how does improving heart health diminish risk of Alzheimer's and depression?
Well, we think depression is actually an inflammatory disorder. The inflammation, there's a drug we give people with multiple sclerosis called interferon.
I've heard of that.
And what's the side effect of taking it? Depression. So it's an immune modulating drug that changes the inflammation of the brain and spinal cord, and it can cause depression. It decreases the inflammation. Yeah, it blocks it. And so it's one of these things that you really, and we look at these chemical messengers of the inflammatory system. When you get like a little splinter in your finger and it gets all red and swollen, that's a good inflammatory response.
Yes.
When that's happening day after day after day, that's the dysfunctional inflammatory response that leads to what I think are some of the root causes of depression, dementia, and for sure heart disease.
Inflammation.
Yes.
Chronic low-level inflammation.
Well, I thought heart disease was a plumbing problem, that you just filled up your artery with plaque and then you had one little spot, you had a cheeseburger and it knocked you off. That's not what happens. You can have a 20% or a 90% plaque, and when it gets inflamed and irritable, then it ruptures like a zit, like popping a zit. That's what starts off this whole clotting cascade that we're talking about with estrogen.
So it's the inflammation.
It's the inflammation on the plaque, not just the plaque by itself.
Now, between men's and women's hearts, so I assume if we were in an autopsy room and we were doing an autopsy and a heart were in front of you, would you be able to say that's a female heart?
You definitely do see a difference, and you see a difference in the coronary anatomy. The arteries of the heart that supply the muscle with blood are different in men and women.
And also, how is it different?
It's the structure and the way it responds to inflammation because of the hormonal milieu that is a woman's health. And it depends. What's your toxicity levels? What are your nutrient deficiencies? What's your stress? All of those things combine to make the heart more vulnerable. I think stress is actually good. It's what got me to come to New York and see you. And stress is a good thing. It's how we internalize it.
Yeah.
My favorite story is it snowed about 4 feet one day a couple years ago. The first woman walks in and says, "Oh my gosh, look how beautiful it is. I love the trees. I love these snowstorms."
It's beautiful, yeah.
The next one walks in and goes, "Oh my gosh, I'm going to slip and fall and break my neck." So the same storm had two different internalizations. One woman is in a better space than the other. And we think that those negative internalizations, it's not just stress, it's the angry, hostile, deep resentment type of held stress. That's the danger stress. And that's what we really have to help people to let go of.
Now, so with men's and women's heart, the physical difference, women's hearts this is what I understood from your book. Women's hearts are smaller, and it's not relative to height differential. Like, in
Right.
other words, I'm call me 5'4", 5'4", 5'5". What are you?
I'm 5'11".
Okay, so what I understood from your book was my heart is the difference in size between my heart and your heart isn't relative to that 7-inch
not.
difference.
No, it's not.
So my heart has to work harder, more beats per, it has to have a higher resting heart rate, a higher, that kind of thing than a man's heart. Is that accurate?
It is to a point, but when you look at the heart and when you look at those blood vessels that surround the heart to provide it with blood, they're different. The caliber's different. The shape is a little bit different, but everyone is unique. Some people that we saw have 1, some have 3. So you can think of your heart as big as your fist.
Yeah.
And you have 3 pipes that run around it.
Mm-hmm.
These two arteries and 1 branches off. And it's different in almost everybody. There's a set pattern that most people have, but you see all these different variations. We kind of think that we're pretty similar.
Yeah.
We're really quite different when you get down to the molecular level. We're only about $11 worth of minerals and salts when you go down in our bodies. If you were to grind it up and sell it on the open market, we'd be worth like $11.
And everything else is
The minerals, everything else is related to that. But we're just electrolytes and minerals. We're not really anything much more. But it's the proteins that cause it, and they're the ones that drive this inflammation response. And women have a different inflammatory response than men do. And it's not universal, but it's really a combination. You put caregiving stress with hormone imbalance.
With I work full time.
On top of, well, ma'am, if you would just eat less and exercise more, all that weight will magically go off. Well, you hear that for 5 or 6 years. And when it's actually been your thyroid and your adrenals and your hormones or nutrient deficiencies or toxicity, it's no wonder so many women are frustrated with what they're seeing in the medical office today. We can just do a better job.
I also know, so general signs and symptoms of a heart attack. A man could be having a heart attack and have different symptoms than a woman having a heart attack. So I wanted to review some of these so people understand. So symptoms of a heart attack, generally speaking, we think of the squeezing or the chest pain, the pressure, shortness of breath, sweating, the tension in your chest and elephants on your chest.
That's the classic one, is the elephant on your chest.
Pain spreading to the shoulders, the neck, and the jaw.
And I don't think I've ever heard a woman use that term.
Which term?
An elephant sitting on my chest when they've had heart disease, when they've had a heart attack.
Really?
I don't think I've ever walked into an emergency room or into a critical care unit and had a woman say, oh yeah, I had the classic elephant on my chest.
Crushing.
It's always something different. So it can show up as anxiety, irritability, nausea, abdominal pain, vomiting. It can look like your gallbladder or it can look like an ulcer, but actually be the heart. So women just show up differently. In that Grey's Anatomy episode we talked about, the chief surgeon, she demanded a second opinion. They brought a psychiatrist.
Oh, see, that's so...
And that's classic. That's what we see. And if you and I get chest pain, go to the ER, it's very possible that you may walk home with anxiety medicine or heartburn medicine and I get admitted.
But again, a woman could be in cardiac distress and she could have nausea, fatigue, vomiting,
dizziness, palpitations. It doesn't have to be the classic heart symptoms. And I like to tell women, you don't want to be a hypochondriac, but if you think it's your heart, get checked out because you don't want to be wrong.
Right.
And the numbers are just not in your favor, that if you think it's your heart, go get checked out and be sure it's not. And there's some new testing that's out there that most of us are not doing. We're still stuck in the 1970s testing model.
You mean like tension in chest? Or
our cholesterol testing. I mean, the classic study was the Framingham study. 40% of people had a normal cholesterol that had heart attacks.
Yeah.
So half the people that have heart attacks have normal cholesterol. And the other half that have high cholesterol never have heart attacks. So it's not just about your cholesterol. And we look at the good one and we make a ratio for women. We look at your total cholesterol. We look at your good cholesterol. We make a ratio. I don't treat ratios. You don't want to be treated like a ratio. You want to be treated like a unique woman that you are. So these kind of easy things that we've used, these kind of calculators and factors, I think is a mistake for some people because it's you in front of me. I got to take care of you. I want to use the evidence guidelines that are out there.
Right.
But at the end of the day, I'm treating you and your story, and everyone is unique. They're very, very different in how they present, how their bodies are metabolizing, and we all have our own different types of challenges.
Yeah.
But in women, we see these common patterns.
And you talk about, so in your book, you write to be what you consider to be the top 7 myths about heart disease. So I want to dispel these. You just began to talk about one. Myth number 1 is high cholesterol levels cause heart disease. And the reason, like, what the hell is high cholesterol? Are we talking LDL, HDL? So talk about why that's just stupid.
Well, that's like what I was saying with, let's treat you by calculating a ratio to see what your risk is. So you could be the most fit woman like you are,
okay,
and have the same risk scores as someone who doesn't exercise at all. How could you guys have this?
And smokes.
Well, when you have diabetes, when you smoke, those are individual additional risk factors.
Okay.
But you could be someone who's fit and conscious about your health and eating clean like you do,
okay,
versus someone who's not. If you've got the same cholesterol ratio, you've got the same risk. How can that be? And that's where I think our guidelines may fail us. They don't look at who's the individual in front of you. So we have all these studies, and in internal medicine, I want to be able to quote the latest double-blind, placebo-controlled multi-center trial, the Jupiter trial, the ALHAT. But at the end of the day, I'm treating you. It's an N of 1. It's you and your story in front of me.
So you're saying the reason you don't look at high cholesterol levels cause heart disease is because, like you said, you could have 2 females. One could be, you're out in Jackson Hole, Wyoming. She could be a cross-country skier and eat clean, organic foods and, fresh and this and that and the other. And her cholesterol panel might look identical to a same-aged woman who lives on fast food and sits and watches television.
Yes, and we're going to give them the same treatment. It makes no sense to me.
Okay.
So the first thing is you have to go beyond the traditional cholesterol test. It's like $80 more to get these fractionated scores. You take that bad LDL and you break it up. There's 4 subparticles. One's known as lipoprotein A. Have you heard of that before?
Well, yes, because I've interviewed cardiologists.
Yeah, and that's the scary one for women. It's the small sticky of the cholesterol particles, and it's got a little inflammatory tail on it, and it looks like that under the microscope. It's a little hot ball with a little sticky tail, and it's really what drives, I think, the cholesterol theory for women. That's why cholesterol is bad, because these particles. And now you can also measure the inflammation at the artery level, and you can help predict who is going to have a heart attack. So
is that by way of C-reactive protein? Is that what
that's the one that's been around about 15 years.
Okay.
The new ones are plaque 2, myeloperoxidase, and oxidized LDL. Those are the 3 new inflammatory markers that we check in our clinic.
Is that when you do the fractionated cholesterol?
There's a fractionated and there are the advanced inflammatory markers. So you want to ask your doctor, first of all, he may have no idea, he may never even have heard of lipoprotein A or myeloperoxidase or plaque 2. Very few doctors that are not doing functional medicine are not even aware that these tests are out there. And
does this tie in with myth number 2? Is this what we're talking about already? The total cholesterol test gives me a good measure of my heart disease because it accurately measures LDL and HDL. That's a myth, and this is why. Is this what we're saying? Okay, so you're saying you need to take it. Okay, you're saying HDL and LDL are not enough. You say take it one step further, ask for a fractionated test.
So if 2 women have a cholesterol of 250 and they have the same good HDL and the same bad LDL,
yes,
they have dramatically different risks when you look at these fractions and these inflammatory markers.
Okay, so tell people, what test are we asking our doctors for? I want a fractionated
cholesterol to look at lipoprotein A and small dense LDL. Think of them as the small sticky bad particles.
Okay.
Then you also want to look at the inflammatory markers, C-reactive protein, myeloperoxidase, and plaque 2. Okay. There are labs all over the country. Quest does it. You can get that lab test through any doctor. The problem is most doctors have no idea what we just talked about.
C-reactive protein they do, but
CRP they
there.
do.
Yeah.
And the data is pretty clear that these additional markers find them. For all the women listening, there's 3 things you want to do. One is get the advanced cholesterol test. You deserve it. Get it.
Okay,
see what
that's
your
what
risk
it's called, advanced cholesterol test with fractionization.
Exactly. And the inflammatory markers. And you can start with the CRP. It's a good start. But at some point, you deserve to get a full cholesterol panel and a full inflammation panel. The second thing is don't ever do a stress test. If your doctor says, well, let's just do a stress test to see who you are, women have notoriously passed stress tests when they have full blockages. So if you're active at all, you can fool a treadmill stress test. So what women want to do...
So highly conditioned women can do well on a treadmill stress test and have 90% blockage.
And still be at risk. I saw that all the time. And we saw women who were cleared for surgery that then during the surgery would have a heart attack because they actually were not able to mount the blood response that they needed to. So it's a treadmill echo. It's an echocardiogram or an ultrasound of the heart.
A stress echo.
Yes. For men, we do this calcium scoring. For women, we do the stress echo, and we also do the thallium for men. But we don't like to radiate women's chests. So the stress echo is the stress test with an ultrasound. There's no radiation at all. Plus, women tend to have more valve problems with the heart, and you can see the entire structure of the heart, not just how strong and healthy it is or what your risk is, but it does all of the valves and all of the chambers of the heart.
A stress echo.
Stress echo. And then the third thing is the new technology called a CIMT, carotid intima media thickness. We've been doing ultrasounds of the neck arteries for decades. This now looks at that lining. It's a 4 or 5 millimeter measurement. It's very fine looking at the lining of the blood vessel.
Is it a sonogram?
It is. It's ultrasound also.
Okay.
It's got a special CIMT because it's the carotid intima media thickness, or the lining of the blood vessel. So those are the three things that if you think you might have a heart risk, you need to get all of those done.
And that will look at the blockages in the carotid arteries.
What it looks at, it gives you a vascular age. It tells you the age of your arteries. And what's great is you can track it over time and de-age your arteries.
Now, what is that called, Doctor, again?
CIMT, carotid intima media thickness.
And that is a sonogram.
It is. And they're in most cities. It's just getting the recognition that it deserves. But again, I didn't speak of a single radiation test. You can get all of these with a simple blood draw, a stress echo ultrasound, and then a CIMT. And if you pass those, it's almost impossible for you to be at risk for heart disease.
Okay.
So we have the tools, and we're doing them regularly in our clinic as we look at the whole person.
Now, myth number 3, this is so stupid. I can't believe I just can't believe it's still a myth. Fat is bad for the heart. Isn't that from like 1973? Isn't that what we said in the 70s?
Well, Dean Ornish was a real low-fat proponent, and that any fat was bad fat, and he got amazing results showing reversal of heart disease. But we're now breaking that up into the good fats, bad fats. Yeah, so not all fats are equal.
That's one thing I was going to say about Dr. Dean Ornish. No disrespect to him whatsoever, but I can't eat low fat. I just can't.
Yeah, and there's a big argument
Don't work.
in nutrition. So what diet should we recommend? None, because the first 3 letters of diet are die. I don't believe in diets. I believe in personalized nutrition programs.
So explain why fat is not bad for the heart.
Well, we're all fat heads. Our brain is fat. It's 4% of our body weight, uses 20% of our energy. So we need good fats to help make our nervous system, to help keep everything in check. It's the bad saturated fats, the processed food, the fast food. I kind of use the rule, the things that are hard at room temperature, like bacon fat, ham fat, butter, those tend to be the saturated fats. That's an easy way for people to try to identify them.
But isn't there an argument, because I eat plenty of saturated fat, but I don't eat junk food. In other words, to me, there's a couple ways to get saturated
Absolutely.
fat. You can have organic grass-fed steak or organic chicken, or you can have animals that are organic and very clean, and that's a way of getting saturated fat. You can also, don't you get saturated fat when you get French fries from the fast food joint?
You do, but they are different in their potential for oxidation in the body and for causing damage to the blood vessel.
So don't you agree that saturated,
Absolutely.
because I don't think saturated fat is necessarily bad. What I avoid is sugar in my life.
Well, that's a whole nother story, right?
Yeah.
and how do you get a can of soda pop full of sugar? Eat a slice of bread. Any slice of a bread product has the same sugar load on your body as a can of soda pop.
Well, we'll save sugar for a second. Let's get back to the fat thing, though. So you're not an advocate of low fat, are you?
Everybody's different. Some people really do well. It's kind of like the intermittent fasting and the Atkins diet and all these nutrition fads. Some people really do well with them, and some people don't. I think you really have to look at the whole person to say, number one, what do you want to eat? What are your beliefs? What feels right? What feels right? And trust that. That's called food intuition, and trust it.
Yeah.
I kind of am a doctor of moderation. I think everything legal you should be able to have a little bit of. And so you have a steak. If you can get a grass-fed one, you're way better off.
Yeah.
Because of the hormones and antibiotics. But I don't think there's anything that should be absolutely taboo in nutrition. And it may be that you just have to develop what works for you. And then you have to cut some things. Really, the fast food French fries aren't good for anybody. But if you have them once in a while, I have patients that will stop at McDonald's and get a French fry once a month. Mm-hmm. I'm not going to argue with that. I think that the joy and fun they have with it is great for them. But if you're doing that every day for your lunch, then it becomes a problem.
Right. Okay, so again, fat, because I'm a big believer in fat myself, and I think it helps with depression.
I'll say myself, I'm a fathead.
Yeah, me too.
Yeah, but we are. Our brains are all fat. We need those good fats. And again, the quality and the source is paramount.
Okay.
As you mentioned.
Myth number 4, if I consume less cholesterol, I'll be healthier. This was when people stopped eating eggs because they are in what isn't shrimp, like
yeah.
So stupid.
Eggs are interesting, aren't they? I had one the other day, and it was yellow, almost white, because there was no nutritional value of it.
Where'd you get the damn egg?
It was just at a local hotel restaurant.
Ew.
And my neighbor who raises his own chickens and feeds them high omega-3 grain, the yolks are bright orange, almost red. And I just got to think that there's different nutritional value between those two eggs. So the quality is such a paramount.
But if you consume less cholesterol, be healthier, that is a myth.
Well, again, it depends on everything else that you do. If you have a sluggish metabolism, your thyroid, your adrenals, your hormones are out of balance, you have leaky gut, you're not absorbing your other nutrition, you have stress in your life that's toxic to you, you're getting exposed to toxins in your daily life, then it doesn't really matter what you try to do right because you're already kind of behind. So you've got to look at all of those together.
Right.
And if you do, then it doesn't become a big issue.
If you do look at everything, then if everything else is in check, eating eggs and shrimp and eating cholesterol, because I was always taught eating cholesterol doesn't raise your cholesterol, because for God's sakes, if it did, I'd be dead. No, because here's a perfect example. Same family, my baby brother, my little brother, because we're the same genetic material, same parents. He has high cholesterol no matter what he does. Sadly, he is on a statin. It's not something I agree with, but that was his choice. I'm his big sister. I don't have high cholesterol. We're from the same parents, and he's doing everything right, but his body just makes more cholesterol.
And so he believes, figure out why.
He believes that eating cholesterol, but what I'm saying is eating cholesterol doesn't make you have high cholesterol. It just doesn't.
Yeah, it does for some people, and it depends on what your source of cholesterol is, as you mentioned. If you're eating healthy sourced meats,
yes,
then it's a lot different than eating non-healthy sourced meats as far as the inflammatory potential. Everything kind of comes back to meat.
So everything kind of comes back to it all depends, right?
In what else you're doing right and what else
quality.
you're doing wrong,
Yeah.
and then the quality is just queen.
Myth number 5, modern medicine treatments can fix your heart. We've already said at the top that that's not true because women who go in for bypass surgery are 4 times more likely than a man to die after surgery.
Well, yes and no, but they may need the bypass. What's interesting right now is the stents, the little cages that we put in arteries. It looks like they may not be a good idea. They may actually increase your risk of having a second heart attack.
Why?
The data shows that by doing traditional medical management, you actually get the same outcome as putting a stent in someone, and there's a risk of puncturing the artery when you do a stent. So the data is getting very interesting. And I'm not anti-procedure. If I have a stroke, I want the clot-busting drug. If I have a blocked artery, I want you to open it. But what we're finding is these elective procedures may not be such a great idea. And the statin drugs, I'm not anti-statin, but there is a very narrow group of people that they really benefit. And your brother should figure out if he's one of those. You do a coronary calcium score, you get the fractionated cholesterol, and see if you're that one at risk. And
even so, I would start with red yeast rice and plant sterol. I'm always the person who, before you take the pill, why don't we figure out?
Well, it's interesting because there's no real data on red yeast rice and the plant sterols that they have a mortality benefit like the statin drugs do. So there are some people, a man with known heart disease does seem to benefit from the statin drug. And I think it might be that the statins have an anti-inflammatory effect. The C-reactive protein you mentioned, there was a classic Jupiter study that showed it reduced the CRP by taking a statin. So maybe they work on inflammation as well as cholesterol.
But again,
cholesterol.
But didn't you just say that people with known heart disease benefit from statins?
That's what the data suggests. It's typically men with known heart disease are the ones that benefit the most. They studied women in England.
Okay.
Under age 50, you had to treat 5,000 women to prevent one heart attack.
Using a statin.
Yeah, so this number needed to treat is kind of a complicated statistic, but what we really want to know is not did 30% of people get better, but how many do you have to treat to prevent one bad thing? And the number needed to treat is somewhere between 200 and 500 for women postmenopausally, regardless of their cholesterol, to take in the drugs. So that means over 5 years, you have to treat 500 people for 5 years to prevent one heart attack in women.
That's not worth it to me.
Well, I think what we're seeing is a lot of the studies now are going back to these number needed to treat and also number needed to harm. How many people get hurt by the therapy and how many people benefit. And then we make a decision, should we even use these therapies? And for women, the cholesterol drugs don't look like they're a great idea for most women.
Yeah, they seem to be prescribed. They're given out like cocktail peanuts.
I was told they should be in the water when I was in medical school. And we're finding that for some people there is a benefit, but you've really got to, why would you not fix everything else too? And then maybe you won't need one.
Okay. Number 6, well, we just talked about statin drugs. Statins are safe and will reduce heart attack risk for those who take them. You've just answered that. There's a narrow population of people for whom this is true. There's a greater population of people for whom this is not true. And if you use lifestyle management, you won't even need it. Is that accurate?
That's my feeling. And even the National Institutes of Health says you should try lifestyle medicine first before you go to a cholesterol drug. But that's not what's happening. Everybody just reaches for the medication because it works. It knocks the numbers down, but it doesn't really lower your risk. And in all comers, it may not, particularly in women.
Well, and it lowers CoQ10 levels in the body, and you get muscle weakness and muscle aches.
I heard a cardiologist say that we've created the largest vitamin deficiency on the planet. It's CoQ10 by giving statins. And he may be right. I see some people that are exquisitely sensitive to the medications, and they just can't tolerate them due to their muscle breakdown.
Okay. Myth number 7, dieting to lose weight is the key to reversing heart disease. Dispel that, doctor.
Well, again, I don't like diets because they're short-term solutions to long-term problems. I think you need to develop what is your personal nutrition. The Mediterranean diet looks like it might be the best. It reduced all-cause mortality 50%. What that means is it reduced your risk of death by half by eating Mediterranean.
Yeah.
But it's different in Greece and Italy and France. And you know what I think?
Wait, you mean it's different in Greece and Italy and France than the way we do it here?
Well, even in those countries, it's slightly different. It's the same kind of core. Mm-hmm. It's clean food, basically. But it may be coming together and sharing a meal with people that you love is what turns the food into good food, not so much just the food itself. That's something that I've really wondered about is the way you share your meal and the way you eat your meal with intention, with intuition about what you do, and with love and gratitude. That may actually be more powerful than any medication or any diet.
Well, I don't know if you ever did this. Did you? I lived in Spain for a year after college. Have you ever done anything like that?
No, I want my kids to do that. I think I missed out not doing that.
So after I graduated from college, I went off and I lived in Spain for a year, and I lived in Madrid with a Madrileño family, a Spanish family, right. And the mama, she would cook, and she would make the paella with the yellow rice and this, and the food was fresh and delicious, mm-hmm. and it was home cooked, and that's typical Mediterranean. I mean, it was fish and vegetables and things like that, and olive oil and stuff. And those people do something right. I'll say that. And in Spain, I saw very little obesity. Now, this was years ago, sure. In 1987. I'll say, so it was years ago. But I saw very little obesity, yet people were eating and enjoying food. And
food's a passion, and it's part of a family type ritual. And I think there is something really to that it's not just the calories. It's the energy that you bring to the meal.
But also, I agree with you, just dieting to lose weight, because you can lose weight in a very unhealthy way. You can lose weight living on ice cream if you just, there's a lot of ways to lose weight. And basically what I understood this myth to say is just losing weight, just lobbing off 50 pounds, however you happen to do it, isn't necessarily a heart health strategy.
Yes. Well, we see women that get liposuction that still have diabetes. So they get rid of 20 pounds of body fat, but it doesn't change your metabolism.
Yikes. Yeah. Now, we already talked about inflammation. You dedicated an entire chapter to that, causing it essentially the root cause of all disease. And I agree with you 100%. And when I was reading that, I was thinking, the reason inflammation, wasn't it in the 70s, the early 70s, when high fructose corn syrup was invented? Am I correct with that? Yeah. So we cooked our own goose.
We did.
When we started with that crap, and then things just kind of got worse from there. And there's so much coming at us and we're so highly inflamed just from everything we're breathing and everything we're eating. And it's this low level. I want you to emphasize to everybody that it's a low level. You can't see it.
Yes.
You can't feel it. You can't sense it, but it's there and it's killing you.
So it's like when you sprain your ankle and it gets all red and swollen.
Yes.
That's what's going on inside your heart every time that you're having these inflammatory foods, every time you're having a stress that you can't cope with. All of these things just drive that process. So it's the same chemicals. It's just in the acute reaction of a sprained ankle or getting a splinter in your hand, it's a good process that cleans it up and heals it. But it's when it goes on and on and on, whether at the gut level, the heart level, or the brain level. To me, it's all the same thing.
And would you agree, doctor, that at least in this country, and again, this is a podcast, so people in different countries will hear it,
right.
but the world has gotten so westernized that I feel like whatever pertains to us pertains to other countries too. When you're having this constant onslaught of bad food and processed crap and sugar and soda and chemicals and this, you're just constantly inflamed.
Yes.
You're just always inflamed. It doesn't matter what you weigh. I don't care what you weigh. And see, and this is the problem, and I'll tell you this. Back in my day and in your day, we were taught the route to weight loss was counting calories.
Yes.
Doesn't matter what you eat. Doesn't matter. I mean, you could eat like ice cream, breakfast. You could have ice cream and chocolate milk, breakfast, lunch, and dinner. But if you count your calories and you lose weight, that's good. That's what I was taught. Nothing could be more screwed up than that.
Yes.
Because on the outside, you look all good. You fit into your dress. And on the inside, you're dying.
Well, we talk about the hot fat, the visceral fat. So you can be a skinny fat person. No one likes fat on the outside, but as a doctor who cares about you, it's the fat on the inside that makes me more concerned. And you can actually test for that. There are scales called Bioimpedance Analysis, but they measure through an electrical charge what your internal body fat is. And that's one thing that we find surprisingly, a lot of women that look good on the outside, but they're inflamed on the inside. And they're holding that visceral fat around their liver. It's called fatty liver, which is something I never want. But there'll be more liver transplants from fatty liver in the next decade than from hepatitis.
Well, you know what, though? Also, fatty liver disease used to be from when you're an alcoholic, right? I mean,
it's a different. This is non-alcoholic fatty liver
right,
disease.
But that's what now they've had to come up with non-alcoholic fatty liver disease.
They had to create a new name for it.
We're so damn fat that we have another reason to have liver disease.
And it's really all about insulin resistance, which is pre-diabetes. And it's just, these magical numbers we talked about. Why is 100 a good number for your blood sugar? It should be 90. Yeah. So by the time it gets to 99, you're already in trouble. So that's the thing about medicine is we make these arbitrary numbers that we've set. They're not arbitrary. They've been studied, but we set these cutoffs where we don't really do anything until you pass that cutoff. And then, oh my gosh, you get a medication. Why would we not get the wheels spinning before they come off the bus?
Yeah.
And that's what everybody wants. That's what you want for yourself, your partner, your kids, your parents. That's what we're doing with this whole integrative functional medicine model.
Well, I'm actually glad you brought up insulin because you say in the book, and I want to just plug this book. I love this book, Heart Solution for Women. Heart Solution for Women. You say in the book that insulin, while vital to our health, God bless insulin, right? I mean, we need insulin. It's the most inflammatory molecule produced in the body. And this is why we're in such a pickle.
Yes. Well, we spike our blood sugars. And so you can have a good fasting blood sugar at your doctor's office.
Okay.
But your response to sugar loads is driven by insulin. And we have a lot of people that they have an exaggerated insulin response that lays down that fatty liver, that lays down that visceral fat, that creates this inflammatory, toxic environment by driving the blood sugar through this elevated insulin. And you can miss it on a blood test.
Well, do you, doctor, I prefer rather than a fasting blood test, I prefer an A1C. Do you?
So there's a test called the glucose tolerance test. Have you ever had the pleasure of having
That's
one of those?
old school. That's old school, right?
It is, but it's still used where they have you come in fasting, check your blood sugar, drink this nasty 70-gram orange liquid, and then check it every half hour for an hour and a half. Well, what we would do is we check the fasting insulin, which I think is a better measurement of what's really going on. And we have what we call the Muffin Test. Is we check their fasting insulin, we send them to the bagel shop, have them get a 600-calorie muffin, and check their insulin 30 minutes later. And what we see is the blood sugar doesn't move that much, but the insulin skyrockets. And these are people that are set up for fatty liver, for diabetes, and have no idea because their A1C looks good and their fasting blood sugar look good. And the A1C is interesting. Some smart doctor figured out your red blood cells live for 4 months. Let's figure out how much sugar they carry on their journey.
Okay.
And that's what this hemoglobin A1C is. It's a 4-month marker of what your blood sugar's been.
But you don't love
But you
it?
can miss it. You can get, you can miss this early warning that this insulin resistance is happening if you check the fasting insulin or do an insulin challenge, like I mentioned.
Okay, so this is what I'm hearing you say. Instead of looking at fasting blood sugar where they go, oh, it's a 94, or doing an A1C, which is, I was always taught it was a 3-month look at, you're saying, no, we should be looking at insulin response, how your body, because you're saying there are certain people who, upon eating a muffin, their insulin dumps out.
Yes.
And then are you saying that there are also people who eat the same muffin and they have a
Yes. And that may be related to your gut health, your toxicity, your liver health, your hormone balance. And so we
or
talk.
possibly genetic, right?
Yeah, it is. The genes, I'm so glad you mentioned that because there's this concept of epigenetics, which is the most empowering thing in medicine, that you're not your parents.
Yeah.
You're not your brother or your sister. You have the ability with your lifestyle choices to turn on good genes and turn off bad genes. That's very empowering. Rather than people just thinking they're doomed to have a heart attack because their mom did, that you can actually turn off these bad genes and turn on good ones based on your lifestyle choices. And all you have to do is vote with your fork.
So basically what you're saying, getting back to this insulin challenge thing, you're saying if genetically you're kind of set up to be a person who eats the muffin and has a huge insulin response, how can we change that about ourselves? Because to me, the way your insulin responds is just the way it responds. Now, I cannot promote that by not eating muffins or by keeping everything low glycemic, meaning not eating things that promote blood sugar spikes.
Yes.
But how can I change the fact that my body just tends to dump out a lot of insulin?
Well, you mentioned the testing, the glucose or sugar, the A1C, and then I mentioned the insulin. If you're to pick one, I'd put my money on the insulin.
Okay, and what do you call that,
diabetic.
doctor?
You just do a fasting insulin. That will tell you with this body composition more about your metabolism than any other thing you can do.
So we go to the doctor and we say, I would like a fasting insulin test.
If you're going to do my cholesterol and check my numbers, and you should do it fasting after 9 p.m., you can drink water in the morning, and you should, that you ideally can look at all three. But if there's cost is an issue, the insulin is the most telltale of your blood sugar.
And it's called a fasting insulin test.
Fasting insulin. And you can do the challenge test, but you don't really need to. You'll see this insulin perturbation before you see anything else. Did you hear the story about the genetically identical mice?
No.
They fed 1 extra calorie, so they took the fat mouse and its genetically identical brother, a skinny mouse. They took the microbiome or the gut bacteria out of the skinny mouse and transplanted it to the fat mouse. And what happened?
He got lean.
He got lean. So it's not calories in equal calories out. Your body's bacteria will extract more calories than other bacteria. So what's going on in your gut could make you fat. That this leaky gut, dysfunctional gut, imbalance of bacteria. Do you know there's 10 times more bacterial cells in your gut than human cells in your body?
Because I heard we have trillions of cells in our bodies. So
half the
10 times.
Yeah, half the DNA in your body, it's not yours. It's this microbiome. This is how complicated the gut is, and we're just scratching the surface of it. But we do see that if you don't get the gut healthy, you can forget about trying to lose that body fat.
But are you saying, doctor, that there's a correlation between the gut health and your how you would score on a fasting insulin test?
We see that a lot, and what the common link is this internal visceral fat. That women tend to lay down that fat inside, and you can't see it from the outside.
Right.
So by the time you realize it's going on, you may actually have a much more difficult time reversing it. And the fasting insulin will find those people for us. We call them the skinny fat people. If someone's obese, it's pretty obvious they probably have a blood sugar problem. But you and I don't look like we would, but we could. And it could be a signaling problem from the gut, thyroid, adrenal hormones. So you have to get all of those ladies balanced.
So a fasting insulin test.
Yes.
And you brought up the gut to say, is that to say that when you heal the gut, you can somehow heal the response that your insulin has? Is that what you're saying?
You can. And, diabetes is reversible. There's two kinds of diabetes. One that you're born with or that you get at a young age, that's a pancreas failure problem.
Yes.
That's the type 1 type of diabetes. That's insulin dependent. The other is a lifestyle disease. It's typically that people are overweight, their hormones are out of balance, their thyroid's not working, their metabolism isn't working. And if you fix that, really diabetes should be obsolete. And with the new functional medicine and integrated medicine tools, it should be obsolete.
And instead, I was watching this documentary. A little obese 4-year-old boy had diabetes. When you and I were kids, it wasn't called type 2 diabetes.
Yes.
It was called adult onset diabetes because your fat old Uncle Johnny got it. No, I had a fat old Uncle Johnny. And I remember we would have these parties. Because big Sicilian family, you're Italian, right?
Yes.
You know how they eat?
Yeah.
And Uncle Johnny had diabetes, and so he couldn't have the cake or whatever. But children there was no kids in my kindergarten class with it.
Yeah. Well, it's an epidemic that's coming. It's a tsunami of things like diabetes that are just going to take our healthcare system down. And if you could fix it with lifestyle medicine and not have to burden us with all of the costs. And so, people will talk about functional medicine being expensive because you have to do some additional testing because we're looking at people individually.
You know what else is expensive? Cancer treatments. A funeral's expensive. Do you know how much a funeral costs? Yeah. Like, seriously.
No, you're right. And just the medication costs alone, if we could save our society that and all the testing you have to do and all the complications. But most people that have adult onset diabetes, it's completely reversible.
Amen to that. And you don't have to get it in the first place.
Yes.
You don't have to get it.
Yes.
But if you get it, God forbid, you can reverse it. Now, to ensure that we don't run out of time, I just want you've been talking about the body types, and you mentioned this in the book, so I do want to, we'll jump ahead here, and then I'll go backwards, but I want to get out these 3 body types. You talk about the classic apple-shaped body type, which central obesity.
Yes. That's the one that scares me the most.
Amen to that. It's kind of, I call it like the Humpty Dumpty look,
yes.
right? Like you look like you've got a lot of fat on your trunk and your abdomen. Your arms and your legs look relatively normal.
Mm-hmm.
But you've got, now if you have that apple shape, the central obesity, you definitely have that visceral adipose tissue, correct? The VAT fat.
And you're probably already insulin resistant.
Oh, sure.
You're already headed down that path.
Yeah.
And you can just use a tape measure. Just get a cloth tape measure and measure where your hip bones are, the top of your leg bones, the femurs, compared to the space between your pelvis and your ribs. And that will tell you whether you're this apple type or whether you're more the pear type, which is women that hold it down low.
So you're just describing a waist to hip ratio.
Yes.
Yeah. So I just want to say, do you describe in the...
We do.
Yeah, because I also wrote a blog. Okay, so he describes how to do the waist to hip ratio in the book. You measure your waist, you measure your hips, and then you divide them and it becomes a ratio. You describe how to do that in the book. And I like the waist to hip ratio too, because you and I agree on something. We hate BMI.
Yeah.
Body mass index is just a stupid, worthless height weight chart. So
yes.
So that's waist to hip ratio. Then you also talk about the pear-shaped body type, which a lot of women have.
And that's more of a hormone imbalance, and typically thyroid, adrenal, female hormones. We see that a lot in what we call estrogen dominance.
Okay.
Women that are carrying that lower body fat tend to have higher estrogen and higher bad estrogen, which may be a cancer risk. Do you know obesity is the number 1 cancer risk? Is obesity.
Yeah, I knew that, and it scares me because I know some very smart people who are obese and they don't seem concerned, and I'm concerned for them. Because it's an independent risk factor for so many cancers.
Yes.
It scares the shit out.
Yeah.
Oh, I can't say crap. I can't say bad word, but it scares bad words out of me. but like the pear shape.
I love your passion.
Yeah. So the pear shaped body. I had a girlfriend when I was in high school. She was a classic pear shape. If she was standing behind a table, she looked normal.
Yes.
When she walked around the table, she was like a bell. The bottom of her was like a bell.
Yeah.
And when you could you please explain estrogen dominance? That's where it's dominant over progesterone levels. Yeah.
Yes, and the problem with obesity is that body fat is a factory. It's a hot inflammatory factory making bad hormones. It produces its own estrogens, and they're bad estrogens. There's different types of estrogen that your body makes, and the good ones can be helpful, and the bad ones can be potentially dangerous.
Which are the bad ones, doctor?
There's 3 estrogens, E1, E2, E3.
Okay.
And it's the estriol and estradiol that are safe. Estrone, E-S-T-R-O-N-E. That's the bad estrogen. If anyone's on hormone therapy, they should be checking the estrogens and the estrone.
Okay, so estrone,
Yes.
of the 3, estrone, estradiol and estriol are good.
Yes.
Estrone, we should check estrone.
Especially if you're on hormone therapy. And there's a new test that looks at the metabolism. How do you get rid of estrogen, called your estrogen metabolism ratio?
Okay.
A 2 and a 4 hydroxyestrogen. Do you make good estrogens or do you make bad estrogens? You can tell going into it if you should or should not be on hormones or how balanced they should be. You can also do a genetic test to see if you're at risk for getting that blood clot that happens when women start hormones. So a lot of this that we hear bad things about hormones, if you do the therapy right and you're checking for everything that you need to, then you can use them safely. And it's the lowest dose for the shortest amount of time. But I think a lot of women are going to find that there's a set time in their life where their hormones really help them recapture this vitalness that they've lost. And women just tend to feel better when their thyroid's balanced with the adrenal. And it's the hormone symphony. It's the estrogen, progesterone, the adrenal hormones, and the thyroid. They all have to be in balance. And when that harmony happens and that symphony's in balance, that's when women feel vital. They feel optimal.
Alive.
And not just somewhere in that Grand Canyon normal range like we talked, but where's their sweet spot? And you've got to balance them all. It's not easy to do for a patient or a practitioner. There's not many of us that know how to do it, but there's more and more. We're training them all the time.
But I like that you said that estrogen is a bad estrogen. Estrone is a bad estrogen, and that needs to be kept in check. Why would the body make a bad estrogen, doctor?
Well, that goes back to the genetics. There's a thing called methylation, which is the hottest thing in medicine right now. Is do you take things and make bad things out of them? And some people do. So they tend to send estrogen when you take it as whether you make it or take it, you can send estrogen down a bad pathway that's linked to a higher cancer risk.
So are you saying, doctor, though, all females have estrone?
They have all 3.
All females have estrone, but someone who doesn't handle it well, the estrone levels will get out of control.
And their metabolites, or the downstream converted. When we talked about the liver breaking everything up,
yes,
your liver does that to estrogen as well, and it makes these kind of side effect molecules that are more of a risk. And it's this methylation problem. Some people just don't handle certain chemicals, and it's the same for toxins as it is for hormones.
I'm just surprised that our body would make a bad estrogen in the first place.
Well, it's not that it's bad by itself, but it's when it's the dominant estrogen, it becomes a problem. And when it gets converted to that wrong type, the 4-hydroxy, when it gets converted, the bad one converted to the bad subtype, that's where the risk is. I personally think for cancer risk and hormone therapy.
But every female has a little bit of estrone, so don't freak out if you see it.
And it changes during the month, it changes during your life.
Okay.
These ratios change.
Got it. Now, the third body type that you've already kind of alluded to is the skinny fat body type. And this is interesting. My mother, who she died in 2006, but now thinking about we weren't really talking about skinny fat until recently, meaning the last 10 years or so. I believe she was skinny fat because she was a tiny little person, but she didn't have a lot of muscle on her. And I just believe that had we tested her, that, again, these people look like little tiny people.
Yes. Well, that muscle loss is something that we want all women listening to really think about, because it's not just about your body fat, it's about your muscle composition.
Yeah.
And one thing a woman really wants to do as she ages, hold that muscle.
Yeah.
You really want to hold that muscle for injury prevention. It's called sarcopenia. It's a loss of muscle. It's one of the common epidemic happening to women, and it may be the toxins and men. You really want to hold that muscle as much as you can. And that comes back to how are you absorbing, how are you processing, and what foods are you feeding the body.
But let's go to younger women, skinny fat younger women. How do you become a skinny fat person? Is it by the way, remember what I told you we were doing when I was young, where just count calories and just make sure that your weight stays at a certain weight. That's what, just in college, this is for example, I know you did this too, so don't act like you didn't. But like for dinner, we'd go, hey, let's just go get some frozen yogurt. And we'd get frozen yogurt with a couple different toppings and we'd call that dinner.
Yes.
Don't tell me you didn't do that.
Well, my worst time was during my medical training when you tried to see how many pieces of pizza you could shove in your mouth between rounds.
Exactly, so because God forbid,
we've all had to.
You didn't know when you were going to eat next. But like, it's that kind of behavior that makes you skinny fat, right?
Yes.
You don't necessarily gain a lot of weight, but what you're eating is screwing up your body composition.
Absolutely.
And then you're not necessarily exercising properly to build muscle. So the predominant tissue on your body is fat, even though you're little.
Absolutely. And in residency, we were doing 36-hour shifts every 3 days and eating whatever you could get at any time. And I put on 15 pounds. My blood pressure went up. I was the unhealthiest I've ever been during my medical training. And this doesn't make sense. But this skinny fat is something that really sneaks up on a lot of women. They have no idea it's going on. And there's usually a metabolic change on their blood tests. We can see it when we check these fasting insulins.
What do you see?
We see the insulin higher than it should be. It should be under 10. Most labs say insulin can be up to 24. Mm-hmm. But if I see it, I want it in single digits. It's kind of like your liver test too. Your liver tests, we don't worry about them as medical doctors until they're 4 or 5 times normal. I want them in the teens. So if you've had a recent blood test, look at it and look at the liver test. They should not be over 15.
You mean ALT and AST?
ALT and AST, yes. And there's a better one called GGT, which is a better marker.
GGT. GGT.
Yes. Those are the 3 liver markers. Many labs don't run a GGT, but it's a very inexpensive test. It gives you a better look at toxicity and a better look at fatty liver.
Now, for the skinny fat body type, you said that if you do a fasting insulin, that will tell you if the female or the male, but
yes.
is.
Well, the other thing we do, we have an analyzer in our office that measures your total weight, your total body fat, but also your visceral fat. There are scales out there that will measure this internal fat.
What scales? Because I understand bioelectrical impedance.
Yes, that's what it is.
What scales do visceral fat?
There are most of the bioimpedance will do a visceral fat. It depends on what machine. Okay. We use a company called InBody. It's a $10,000 machine.
InBody.
InBody, and a lot of personal trainers in the city here have them, and all across the country because it's the only way to really track people. You can do the calipers, you can do the underwater weight dunking, but this is an easy step-on 35-second test to tell you where is it. It also measures the muscle in each arm, the muscle in each leg, so we can track people over time how their body is shifting, not just by their weight or what you mentioned, the BMI.
But do you find, doctor, that my beef with bioelectrical impedance is there's such a rate of variability based on, are you dehydrated? Are you
Yeah, and the lower quality machines, that's definitely a problem. They did a study looking at people that did saunas. They dehydrated people and they saw their numbers change just by that. But we get good results with it. And again, you kind of get what you pay for.
It's called InBody, the brand that you use. How can a body type change? I thought that was interesting that you said that. Because I got to tell you, everybody I've ever known, and at this age, at 53 years old, so I know a lot of people who I've known for decades. The person may get smaller, the person may get bigger, but the person's shape, like the people that I know that have central obesity, the apple type, the apple gets bigger, the apple gets smaller. It's always an apple. The women that I've known who have had a pear shape, the pear's bigger, the pear's smaller. It's always a pear. I was shocked that you said, and by the way, when I was in graduate school for exercise physiology, I was always taught the body type is your body type. Like, how do these body types change, doctor?
Well, you are right that there's this mesomorph type body pattern, and there's body patterns that we have. But we see women go through these amazing transformations. The apple body type, again, a lot of times if you get the insulin system working better, you clean up the gut, you balance the hormones, thyroid, adrenal, that body shape will change. The pear body shape is a little harder once you've hit a certain age.
Okay.
It makes it more difficult. Once you're in the menopause time, you're kind of stuck with that body type if it hasn't been addressed pre-menopause.
A pear shape?
Yes.
Or an apple shape, do you mean?
The apple shape you can fix almost any time. We have women that are under age 20. We have women that are over age 70 that shift that body type. But the pair, once you have that entering menopause, you're kind of stuck with it. You can shrink it, like you mentioned, but that pear shape is
why is
typically
that, doctor?
there.
Why didn't we start?
Because it's a longer standing hormone imbalance, and typically thyroid and female hormones. A lot of these women actually are what we call subclinical hypothyroid, or they have Hashimoto's that's never been detected. And if you have Hashimoto, very few doctors even know about
Hashimoto's and not be detected.
Very few doctors test for Hashimoto's. Very few endocrinologists as well. They don't think it's a problem. But we know that it is a huge problem. It's an autoimmune disease. And you're 10 times more likely to have another one. And if you fix the gut, we make Hashimoto's go away in some of our patients.
By what, doctor?
Well, first you got to find out what's driving it. Why is your body making proteins against your thyroid?
Yeah.
There's usually a confusion somewhere. It's usually gut related, and gluten is the big enemy for people with Hashimoto's, for most of them. But there's also a toxicity and other confusions in the immune system of why did it attack its own tissue. And the gluten hypothesis is the best laid out for Hashimoto's. And we see people that come from, long-standing clinics that got tested for celiac disease, which is the wheat sensitivity. Mm-hmm. They're told they're negative, but our advanced functional medicine tests pick it up, and we change what they eat. We personalize their nutrition. Their antibodies disappear, and they come off medication.
Whoa.
And selenium and iodine for some people help with that as well. But Hashimoto's is reversible. And I think actually most autoimmune disease is reversible. At the Cleveland Clinic, they're doing some pioneering work. They put a functional medicine clinic in the Cleveland Clinic 3 years ago.
Maybe you should start running it.
They asked me to move there, and I looked out my window in Jackson Hole and said, probably not going to Cleveland.
Cleveland Clinic.
But it's exciting that the CEO, Toby Cosgrove of Cleveland Clinic, said, this is the future of chronic illness management. I'm betting on functional medicine. So they're doing case studies and looking at autoimmune reversal, type 2 diabetes. It's the future of where we're headed, and our world needs it.
I love that, and I love this book. It's time for me to give my Tamari's tip, and I think you're going to find it quite interesting. So basically, you guys, for my Tamari's tip, I just wanted to give a little story about my life so you can use it as a cautionary tale, because this is something that I never expected to happen to me, and it relates to heart health. You'll find this interesting, doctor, I think.
Please.
So it was about a year ago. It was about exactly a year ago. I started noticing that when I was doing my high intensity interval training at the gym, and I short bursts of cardio where you spike it up to your max limit, your heart rate range for 30 to 90 seconds and pull it back down. And you do that in repetitive cycles of intervals. I started to notice that I was getting like a crushing sensation across my chest. It was transient, and it was accompanied by, being out of breath, which of course you're going to be out of breath if you're in the higher levels of your heart rate range. So I didn't get freaked out by it, but I made a note to myself, this is different. I've never felt that before. Let me watch it. So I kept noticing it happening when I was doing my high intensity interval training. Only then, it was transient. It would happen at the very highest ranges of my heart rate range. Didn't flip out about it. I decided I'm just going to watch it because I have no risk factors. I've never smoked. I don't drink. Cholesterol's good. Blood sugar's good. Everything that can be tested is, no risk factors. One night, and I'll never forget, it was a Thursday night in May. I was at home resting, working. So I was totally at rest. I was not on the stair climber at the gym. And I had that crushing sensation across my chest. Now that flipped me out because I understand if I'm in the upper ranges of my heart rate range, I get it. But if I'm sitting at home in my pajamas typing, I don't understand. The next day was a Friday, and I could clearly recall this day. I do not have a cardiologist. I spent the day figuring out with my insurance who was in my network, and I started calling them. And I kept getting the same story. Oh, yes, ma'am, we're accepting new patients. We can see you in 10 weeks.
Yes.
Okay, yes, ma'am, we're accepting new patients. 8 weeks from today, we can actually, yes, 6 weeks from today. And I'm thinking to myself, well, I hope that they include this in the police report when they find my dead body, that they made me wait 6 weeks. So I kept calling. I just spent the whole day calling till I found a cardiologist, God bless him, who was willing to see me on Monday. I go to the cardiologist on Monday. Same story of my life. They take my blood pressure, perfect. Take my heart rate, perfect. They do an EKG, perfect. I said, Doc, look, something's wrong. I know that I don't look like the type. I know I don't appear to be the type. I'm on paper, I'm not the type. I know everything's measuring correctly, but something's wrong. Please do further testing. He calls my insurance. He gets, of course, insurance gave pushback, but he said, no, she has to have an echocardiogram. So they do an echocardiogram, which is, again, a sonogram of the heart. The echocardiogram showed that I had mild aortic valve regurgitation, just some issues. And he wanted to look into it further. And so he said, Tara, I'm going to order you to go to the hospital to do a stress echo, just like you talked about. Of course, again, a stress echo, you do basically a stress test combined with an echocardiogram. That stress echo showed 3 heart issues that I have that I've apparently had my entire life, unbeknownst to me. It showed that I have patent foramen ovale, which is common, I'm understanding, in 25% of the population. Most people walk around, they don't even know that they have it. Maybe you can explain it. It's a little hole in the heart that after birth, in infancy, it's supposed to close between the right and the left atrium. Right and the left atria. Mine didn't close. 25% of the population, they have it. Okay. The other thing that they found is that I present with features of bicuspid valve, meaning your aortic valve has 3, like it looks like a 3-leaf clover.
Yes.
When I was in utero, 2 of my 3 fused. So I have presentation of bicuspid valve rather than tricuspid valve. That explained the aortic valve regurgitation. I come to find that tends to run in families. My father has had 2 aortic valve replacements.
Wow.
That's just make a mental note of that. Okay. Also, they found that the tip of my left ventricle was not moving adequately. He said, Tara, generally, when the tip of the left ventricle isn't moving adequately, it's because the tip of the left anterior descending artery is clogged. He said, but you've got... look at your cholesterol, your blood sugar, your this, I doubt it's clogged. He said, but let's send you in for a cardiac CT scan to just check this out. So again, he gets on the phone. He's fighting. My insurance doesn't want to pay for anything. God bless my doctor. He fought for me every step of the way.
Right.
Cardiac CT scan sucks. Have you ever had it?
No.
It's not a fun test. I don't recommend it. But if you have to do it, you do it. They shoot dye into you.
Yes.
It's not a good time. The cardiac CT scan, thank God, didn't show any blockage. But it showed basically the same, it confirmed the patent foramen ovale, the presentation of bicuspid valve, and that my left ventricle, the left tip of my ventricle, for an unknown reason, is not moving adequately. So basically, bless my cardiologist, he's actually an electrophysiologist, he said, okay, look, everything is very mild. For now, let's just say no medication, no medical intervention. So what we decided is when I do the stair climbing, instead of going up as high as I was going, I would keep it just under that. So whatever creates the problem, stay just under that. So we agreed to leave that as the protocol, and twice a year I'll go in for an echocardiogram. But my Tara Marie's tip is this. Where there is smoke, there is fire.
Yes.
And I know you tell women this, and so I want to tell women this. If you think there's a problem, there's a problem. And you, as a woman, have intuition.
Yes.
You live in your body every hour of every day, of every week, of every month, of every year of your life for how many years. You know if there's a problem. And if you call to get seen by a doctor and they want to see you in 10 weeks, call another doctor. 9 weeks, keep calling and keep making up, do what you have to do to get seen the next day, or as I did 2 days later. And find a doctor who will listen to you. And if the doctor doesn't listen to you, find another doctor. Because I don't want people to go and have a doctor go, oh, Tara, but come on, your EKG's fine. This is just all in your head. Find a doctor who will listen to you and push, and find a doctor who will advocate and push for you and fight for you with these insurance companies that don't want to pay. Because I'm telling you, if I can have heart problems, okay, so it kind of sucks. I guess I was born with all this. I got a short straw, but to me, the blessing is at least I know I have the problem. At least I know. And I'm aware that I'd rather know I have it than I walked around for 52 years not knowing. Now I know. And I want women to be seen when they need to be seen. I want their doctors to fight for them. And I want women to rely on their intuition.
Yes.
Because I'm telling you, I've never seen a woman think that something was wrong where there wasn't something wrong. And that's my Tara Marie's tip. What do you think, Doc?
The smartest person in the room with me always
is the patient.
Is the woman's intuition.
Yes.
If she knows something's wrong, she's almost always
and
right.
You wrote about that, and you wrote about that in the book. And that's why I decided to give that Tara Marie's tip.
Great.
Because no one else, because I could have been confronted by a doctor who said, "Oh, come on, Tara, go back to the gym and see a psychiatrist." But it turns out I've got all these So that's my Tara Marie's tip.
Great.
And I want women to speak up, to get seen, to demand care, and to demand that if they think there's a problem, there is a problem. That's it. Because I've never seen a woman be wrong about that.
I haven't either.
And you're a doctor, and you're saying that.
Yes.
Yeah. This was a fantastic show. That is all for today. And I'm sorry the time is up because I've loved having you, Doctor.
Thank you.
If you're hearing this episode as a podcast and you want to watch the show, it was a good one to watch. Go to youtube.com/Tara Marie Live. Search for the video entitled Heart Solution for Women. And of course, you can access my YouTube channel from my website, TaraMarie.com. I want to thank my guest. I love this guy, Dr. Mark Menolascino. For more information about his work and the Meno Clinic, which is in Jackson Hole, Wyoming. So catch this. You can go out for a ski trip and then go see Dr. Mark. That's good.
What we do.
It's not a bad idea. At the Meno Clinic, go to menoclinic.com. That's MENO Clinic. MENO Clinic, menoclinic.com. And do yourself a favor, you guys. Get a copy of this book, Heart Solution for Women. It is 332 pages of jam-packed information covering everything you could possibly cover about the heart and integrative health. I love this book. It's available now wherever books are sold. Run, don't walk, get a copy. Please rate and review Tara Marie Live on iTunes, and be sure to subscribe to Tara Marie Live so you never miss an episode. You can subscribe using iTunes or your favorite podcast app. Just search Tara Marie Live. You can find all episodes of Tara Marie Live. They're posted on my website, TaraMarie.com. And while you're there, sign up for my mailing list. You'll get my newsletter with Tara Marie's tips about fitness, nutrition, motivation, etc. And I always send out information about the latest episode of my podcast so you can keep up with what's going on. Connect with me on Facebook and Instagram at Tara Marie Live and on Twitter at TaraMarie_Live. And make better choices today than you did yesterday. You will always be moving in the right direction. Thank you, Dr. Mark. Peace out and God bless you.